Sorry I had to cut that one so short, at least short so quick. Something came up with one of the kids, I had to step away. So getting back to it again, I thought it was the compressive forces that would cause the patient's symptoms. So my hypothesis was to remove the compression force. I had the patient sleep in a recliner for the night, and his symptoms did not wake him up at night. I said, well, okay, if that's the case. I had him come in 2 to 3 times, I think, that first week. After the first visit, I didn't think about that on the first visit. After the first visit, I sent him home with repeated flexion and sitting, and if that made him no worse, repeated flexion and standing multiple times a day, and that didn't make him any worse. And so at that point, I assumed I was dealing with a fairly stable issue. Anyway, after the second visit, I told him to sleep in the recliner. He came back on the next visit. I said, okay, you feel pretty good. Then try to go back to sleep in the bed. Didn't work. Had him in a recliner for 2 weeks. And then after obviously sleeping in a recliner for 2 weeks, I gave him some hip stretching to do during the day. But aside from that, I didn't give him anything else. After 2 weeks, his pain was abolished. I think I followed up with him 6 weeks later. He was no longer waking up during the night. I mean, it's possible he would have gotten there on his own. But again, he had already had 6 weeks of therapy. Didn't get there. This was a relatively quick change in a couple of weeks. Is it possible that the macrophages and the phagocytes had eaten up enough of the nucleus that spit out? Some people that are reading this might not actually understand the difference between that extrusion versus the sequestration. So maybe we'll cover that real quick. There's a research study, I don't know if I cited it in here, I cited it in one of my lumbar presentations, might not be this one, that patients who have symptoms that radiate into the leg with no back pain, it has a high correlation with an extrusion on an MRI. An extrusion is when the nuclear portion of the disc actually protrudes and herniates out of the lining of the annulus. And so it actually leaves that protective space of the annulus. Throughout our life, the body has never seen the nucleus. It's always been enclosed inside. And so because of that, when the nucleus finds its way into the spinal canal, the body sees it as a foreign invader, and it works its way towards eating up the nucleus. At least that's the theory as to why it happens. And so the nucleus that's been protruded and herniated and extruded out of the disc will actually get eaten up over the course of time. The difference between an extrusion and a sequestration: extrusion, the nuclear material leaves the confines of the disc. Sequestration, it not only leaves, but it actually splits. It's no longer attached to it, and it's just free floating. Anyway, that patient was much better. I don't think I really did much for him other than education. Pain that drives the patient from bed. This is the serious pathology. So this is at the bottom of your history portion. With the better worse section, if you circle whatever that activity is, it means that it always makes the patient worse. If you underline it, it means that it sometimes makes the patient worse. And if you cross it out, it means that it has no effect. Again, history. We want to know their previous history. Previous episodes, what happened. Some of the research shows that there could be a gradual worsening of episodes over the course of time. If they had treatment where the treatment's effective, this is one thing that you have to ask. What did they do for you in the past? And it's not uncommon for me to hear, well, I had McKenzie therapy in the past. That means something different to everybody, especially if the therapist wasn't credentialed. That means something different. And so I go through and do my own evaluation. Was there any imaging? We're looking to exclude factors that may contraindicate movement, such as, I'll give you a good example. Patient comes in for an evaluation. She neglects to tell me some stuff purposefully during the history. Kind of irritated me at first. At the end, I still came to the same conclusion, so it didn't really matter, but it kind of irritated me. Patient's a lifelong patient now because they didn't feed me that information, and I still came to the same conclusion. The patient is with me now. Anytime that there's an issue, if their finger hurts, they call me first. Anyway, so this patient comes in. She's elderly, scoliosis, and she tells me about the scoliosis. And she has symptoms that can radiate down one leg or down the other leg. Never simultaneously, but it flips back and forth. Every way that I move the patient, her symptoms peripheralized in some fashion. It either peripheralized down the left leg or peripheralized down the right leg. And with peripheralization, you'll see later on in this presentation, it's an automatic red light. You stop. So because the symptoms peripheralized, I stopped with everything that I did, and I'm like, look, I really think that you need an MRI. You need something done that I can't do for you. And the patient said, all right, well, we actually had that done, and we've seen 4 surgeons, and all 4 surgeons say that we need to have fusion. Okay, thanks for finally telling me. And I take the disc, and again, I've been through the doctorate program, and I've had a lot of experience reading MRIs with physicians. One of the physicians that I used to work with closely took me under his wing for weeks and just showed me how to look at MRIs. And I also had the report, so the report is great to have if you're not comfortable with it, but you can see big picture stuff. We just can't interpret the MRI, or we can't interpret the x-ray. That's outside of our scope of practice. But we can at least look at it so that way we can, curiosity's sake, but we can't diagnose the patient. So understand where our limitations are at in terms of our profession, but they're still fun to look at. So anyway, I looked at this patient's MRI, and it literally looked like somebody played Jenga with her spinal column. There was absolutely nothing was in alignment. I didn't even know where to start with looking at her spine. And if you're familiar with looking at MRIs, when you scroll through the pictures, it changes the orientation of the picture, and nothing was in alignment when you scrolled through. It's like segments were disappearing, and it was it wasn't the best MRI that I had seen by far. Anyway, but it matched what I came up to with the evaluation, which was an irreducible derangement, or a derangement that wasn't going to be affected well with therapy. And because I kept hitting red flags, she ended up with surgery. And like I said, they're lifelong patients. I've seen her multiple times since for other issues, and she's actually doing very well. Physical exam, we want to see the patient's usual posture. This is one of the big debates on some of these forums about posture. I'm not really going to get into there has to be the plumb line posture. Ideally, we're just looking for a posture for the patient to assume throughout the day that's going to be pain-free for that patient. So what is their usual posture? If I change their posture into either a more upright position or into a more slouch position, how does that affect their symptoms? If the patient comes in with an extremely upright posture and they're very erect and they don't have symptoms, but when I allow them to slouch, it tells me something. If they come in completely slouched and I take them upright and it causes their symptoms, that also starts to tell me something. So you're constantly playing with the patient's symptoms when you change their posture. That gives you information. Is there an obvious deformity? Is the patient crooked? Are they bent forward? Are they completely upright and they can't bend forward? You want to take your baseline measurements, basic neuro exam, specifically if you have symptoms radiating below the knee, or if you think that it's the upper segment. Basic neuro exam. Repeated movement exam. Sorry, I was thinking if it's above the knee, you're still going to have the rationale to do lateral flexion, but I think I covered that again in a later slide. We want to look at their posture after 15 minutes, 15, 20 minutes. Let's give them time in that position, and we're going to do their assessment. This is assuming that they're not highly irritable. Some of your patients that are highly irritable, you may actually do your evaluation laying down. I've done that a few times. If the patient just can't tolerate sitting or can't tolerate standing, I'll do my best to put them into a position of relief right off the bat, and then do my history from there. Again, we're looking to see, do we peripheralize, centralize, or does postural correction have no effect on this patient's symptoms? That starts to lead us more towards that derangement, postural, or dysfunction-based category. Standing observation, do they have a lateral shift, meaning does their is there a departure from the midline, meaning are they leaning to one side? It may not be related to the symptoms. I'll give you another quick story. God, I got a lot of stories. It's been 10 years. So this patient comes in, younger, and he's obviously shifted. I mean, he's crooked. And he's got symptoms that radiate from the back into the opposite side of the shift, you know, so it's a contralateral shift. And I'm like, man, I got this. This is awesome. Again, granted, I was in my first year. I thought I knew everything. I'm like, this guy is shifted. Let's fix him. And that's how I used to think. And so I take his history, real quick, and I'm like, all right, we're jumping into shift corrections. I do the basic baseline measurements. Jumping into shift correction and standing. I kid you not, he was doing shift correction for like 40, 45 minutes. And no effect on his symptoms, and I was just sold that this guy had a lateral shift deformity. And so I called his wife back into the treatment area, and I said, watch him walk. Because I'd asked him specifically, how long have you been crooked? And he said, I'm crooked? Dude, you're so far crooked. I've never seen one as crooked as you. And again, words matter, so remember that. Words matter. I was young and dumb at the time. Anyway, so he's like, I've never noticed that I was crooked. And so I call his wife back, and I said, watch him walk. What do you see? She's like, well, I don't know. What am I looking at? I said, he's crooked. Look at him. She goes, you know what he is? I said, okay, all right. You agree with me. How long has he been crooked for? Sorry if that's kind of loud. I get excited when I tell some of these stories. I said, how long has he been crooked for? She said, as long as I've known him. I was like, dang it. I missed it. Anyway, I put that patient through repeated extension and lying, and the symptoms abolished. But it was a 45-minute lesson. Don't think you know exactly what's going on until you fully evaluated the patient. So asymmetry is not a cause of back pain. So just because they're crooked doesn't necessarily mean that they're going to have symptoms. Part of the lateral shift, you've got to see this in order for you to make that lateral shift as your as relevant. It has to be obvious, which his was. It had to be initiated with the symptoms, which I failed to ask that question. Unable to correct the shift voluntarily and unable to maintain the correction. Or maintaining the correction, affects the symptoms and may make the symptoms worse. So I saw what I thought I saw. I went in biased, and I completely failed. Luckily, I was curious enough to keep going, and I didn't give him that to do at home. And I went back and reassessed my evaluation, and before I sent him home, I actually figured out, that I was an idiot. So that was 8 to 10 years ago. I do things totally different now. But I learned from him, and that's one of the things that if you're a new grad, you need to learn from these patients. If you're in a high-volume clinic, man, do your best to learn from all the patients that you're seeing. It may not be the best position to be in at the time, but, try to learn from the failures. And then leg length discrepancy, the only reliable way of testing is a radio x-ray of the pelvis. If suspected, in the book they say place a book under the foot for 5 to 10 minutes and determine its effect. If a patient has an obvious leg length discrepancy and they're coming in with vaulting, after knee or hip replacement, that it's possible that that's affecting their symptoms. So I typically tell the patient, they're relatively cheap. Everybody's got Amazon on their phone. I have them order an adjustable heel lift. And don't come back in until you get the heel lift. This is assuming that I can't change their symptoms significantly with walking through any repeated or sustained motions or even some manual therapy. I can't change their symptoms. And so then I'll have them go out and buy a heel lift. And if that greatly changes their symptoms, then that's a conversation for them to have with their surgeon. And especially if the heel lift fixes it, I'm like, well, great, I'm glad I helped you, but I didn't really help you as much as the heel lift did. This may be a conversation for you to have with your orthopedic surgeon. Neuro exam, paresthesias, weakness of the leg, thigh, or leg symptoms, any symptoms that are radiating down. You want to do your neural screen, sensation, strength, reflexes, dural tension. I like doing the slump test. Sometimes I'll do the slump test in conjunction with the straight leg raise test, depending on how irritable the patient's symptoms are. I think the slump test, or sorry, the straight leg raise test has more research behind it in terms of determining a correlation with discogenic lesions, but the slump test is also quicker and more clinically convenient to do at times. So it really just depends on the patient's irritability, the symptoms, as to which one I'm doing. If I do the slump test and it's positive, I'm usually taking a measurement of like knee extension when they're doing it, or maybe dorsiflexion when they're doing it, as to when their symptoms are produced. So I'm usually taking an objective measure with that if I'm using the slump test. Straight leg raise test, again, I'm taking another measurement of how much hip flexion they go into, because I'm going to come back and use that as a before and after I provide intervention. If you're familiar with the HOAC model, I believe it's called the hypothesis-oriented algorithm for clinicians. You come up with your hypothesis, you test the patient's symptoms, you test some sort of concordant sign, you intervene, and then you retest. There's really two types of systems out there that you can use to treat patients. The first one is pattern recognition, which MDT is based off of pattern recognition. And then the second one is the HOAC model, which is that test, intervene, retest. And for patients, if you haven't seen the pattern before, MDT has it built in to where you just follow through with test, retest. Okay, so movement loss, you're looking for how much loss of flexion or extension do they have. Side glide versus lateral flexion. I don't have it in this study. It's in another one of my studies where I cite the actual research as to why MDT chooses to use side gliding versus lateral flexion. I believe it was 95% of the problems happen in the spine happen between L4-L5 and L5-S1. And so if you're going to test those segments, if you're going to test segments, you want to start testing those segments specifically as best as you can. And side gliding does a better job of moving those last segments of the spine than lateral flexion. They don't necessarily teach side gliding in school, so a lot of my students come out and they don't understand what this means and they don't even know how to do it. Lateral flexion, I think it's L3 and above, as the segments that move the most. So if you have a patient who has L3 or above, you want to do lateral flexion, L4, L5, L5-S1, you may be looking at side gliding more. Getting back to this ANR again, if the patient has a deviation, they may flex towards the affected side. I bring this up specifically. I'm doing my best to try to work with a bunch of different groups of therapists across the country. And in the DPT mentors group, Charlie put up a case which looks suspiciously like ANR. Depending on when you watch this video, we're still waiting for him to give the answer. So Charlie, if you're watching this, hey, get to work, man. Give the answer. Repeated movement exam. So again, you establish your baseline pain location. Pain, paresthesia, numbness, weakness, range of motion loss. You establish your baseline, and then you look at it prior, during, and after motion to assess response. So, like if the patient has, let's say they have symptoms radiating from the back down into the buttock region, you would have the patient perform repeated something, whether it's repeated flexion, extension, side gliding, what have you. You have them perform repeated motions or sustained flexion rotation or hips off-centered. That's more complex than it has to be. You have them do the motion, and you ask them how it is prior to doing the motion. While they're doing it, you ask them about their symptoms, and then when they're done, you ask them about their symptoms. And I don't know if it was in the McKenzie textbooks, if it was something that I heard Robin say, but the most reliable test that we actually have is the patient's response. And the patient is the only thing that is going to be 100% accurate, unless obviously there's a couple of reasons why they wouldn't. And Robin goes on to say, if the patient's in litigation or the patient stands to benefit in some way for not being truthful. We're just going to assume that we're seeing a patient who just wants to get better. These patients are going to tell you what's going on. Some of the things that could happen is you could decrease, abolish, or centralize the symptoms. That means that you have a good direction, or good direction plus force. You could increase or peripheralize the patient's symptoms, or you can make the patient weaker, and you could have a bad direction or bad force. When I say force, I mean loaded or unloaded. They can either be on their feet or they can be lying down. So the force, it might be too much force if they're standing up doing extension, or not enough force. So you always want to look at both direction plus force. Syndromes: derangement, dysfunction, postural, or other. Gosh, it's just like that just rolls off my tongue nowadays. I've been doing this now for 10 years saying those words. Derangement, an internal derangement. For people who are not familiar with this system, this is not a McKenzie term. Everybody believes derangement. It was something that Robin McKenzie created. There are ICD-9 codes for derangement. There are internal derangements of the knee as a diagnosis. It's typically a surgical diagnosis is what they give it, but it's a word that's been out there forever, and literally means that there's a disturbance in the resting position of the joint. These symptoms typically have an immediate response to loading strategies. So these patients can either become rapidly better or rapidly worse. You may find a directional preference in a lot of these patients. You'll typically see a centralization or peripheralization. Directional preference and centralization are not the same thing. I'm not sure how much I cover that in this part. Anyway, so directional preference is, I believe it was the Donaldson study in 91. It's been a while since I've looked at this stuff. A directional preference could be something that reduces symptoms or changes range of motion. Centralization is when the symptoms literally move from a section distal from the spine, closer to the spine. I believe Warnicki, one of Warnicki's articles, has the most stringent criteria for centralization. If you're utilizing another system, you may also hear it called localization. Your goal is to choose the movement that relieves the patient's symptoms. I keep writing pain, but it's about symptoms. It could be paresthesias, numbness, tingling, burning, tightness, pain. And that could either be the flexion, extension, or lateral principle. An irreducible derangement, it gives you an idea as to how long ago I wrote this presentation. They're no longer called irreducible derangements. They're just called, not expected to improve with mechanical therapy. Anyway, all mechanical testing worsens or peripheralizes the symptoms. Somebody had asked, give me irreducible or give me options. That was actually a presentation in I'm just going to guess Baltimore, at the 2010 MDT conference. But somebody asked on one of the Facebook threads, what do you do when you have a patient who has an irreducible derangement or a derangement that's not going to respond to therapy? Move on to functional rehab. Do your best to not make the patient worse and start to get their ADLs better. Dysfunction is the mechanical deformation. I'm going to go back here. Derangement. There's some newer research that's coming out from Susan Mercer out of Australia. She was also, I think she was at Austin in 2013. 2013 was the last conference that I've been to because, every time there's a conference, it seems like we're having a child that month. Child trumps conference. So, but Susan Mercer was, I believe, in Austin in 2013, and she talks about these fatty deposits or these fibrotic tissues that, these fibromeniscoid tissues that may be inside the joints, that they're seeing inside joints. Not maybe, they're seeing inside joints. You could specifically look to her research at the elbow, but they're seeing it in other joints. And so if you could picture, let's just say the knee. The knee works as a hinge joint. There's a little bit of rotation, obviously, but the knee works as a hinge joint. And if you were to take a door hinge, let's just take a door hinge and shove it into that crack that's formed when you open the door over there by the hinges, the door won't close properly, and it may not open any further past that. And so if you have an obstruction of movement, if there's something literally inside the joint, it's going to limit the way that joint moves. That's kind of a real-world explanation for a derangement from Susan Mercer. A dysfunction is a mechanical deformation of structurally impaired tissues, which, this could happen after surgery, after an injury, a muscle strain, what have you. There's a lot of reasons why your soft tissue could be impaired. And so pain is felt when the tissues are loaded in the spine, the location of the dysfunction is, the location of the symptoms are local, except for an adherent nerve root. Then it typically goes along that neural path. Doesn't have to follow a myotome or dermatome, but it can be a referred pain. Anyway, the treatment is the movement that consistently produces the patient's symptoms. I don't know why I keep writing pain. I've changed my wording a lot in terms of talking to patients. I used to always ask about pain. Now I just ask about symptoms, which remodels the tissue over time. The symptoms should abate shortly after stopping the movement. This is key. Yeah, I'm not quite sure, again, how much I go into. It's been a while since I've given these presentations. But when you're moving a patient, the biggest thing you can't do is irritate them. You can't produce and worsen their symptoms. And that holds true along any of these things that we're looking at, derangement, dysfunction, postural, or other. Doesn't matter what we're looking at. If you worsen that patient's symptoms and they remain worse for, I believe it's 20 minutes, you may be starting up that inflammatory effect. And then not only did you just make that patient worse, but you made that patient worse for possibly 3 to 5 days or longer, depending on how far into that symptom you went. And so you really may have just set that patient back. And so, first rule, do no harm. Continue to assess the patient, but always do your best to do no harm. And so if you notice that the patient's symptoms are increasing, you're always talking to the patient. Communication is key with this system. You're always talking to the patient. And so if during the movement the patient's telling you my symptoms are getting worse, stop. What happens? Do they remain worse? Or do the symptoms return back to their baseline? Or are they returning back to their baseline? And again, that's key. You need to stop. Do not make the patient worse. Sometimes it happens. I'm not going to lie to you. Sometimes I'm a little overzealous in trying to classify the patient, and it happens. But I wasn't expecting it to happen. And so, sometimes the patients. I mean, I could say specifically this past week it happened with a patient. And I gave her all of the instructions. I wrote everything down, and I said everything the exact same way I just said it here. If your symptoms increased by performing the movement and your symptoms remain increased for 20 minutes after you stop doing the activity, stop. Do not do anything else. And I wrote it in big, bold print because I realized that I may have a problem with communication with this patient. Wrote it in big, bold print. Put an exclamation point at the end. And after the patient performed flexion, rotation, sustained, she noted that her symptoms were a little bit increased, and so she decided to go through every motion that I did with her during the evaluation. She came back in. She came back in that next day, and I mean, it was like a truck hit her, and yeah, that didn't work out so well. So do your best to communicate with the patient what you're doing and what's your thought process. Do it in layman's terms, obviously. Try not to scare the patient, but always try to communicate with the patient if you can and if they'll hear you. Postural syndrome. This is abnormal stresses on normal tissues due to static loading. We've all felt this at some point or another. We get uncomfortable in one position, so we switch and the pain goes away. Pain is intermittent and local. There's no movement loss. There's no physical damage done. You're just uncomfortable in a position and you move away. There's some theories behind that now that it could be ischemic in nature. That you sit on one thing for a period of time, and that area becomes ischemic. You move, pain goes away, never comes back again. You sit in a slouch position. I'm just going to use slouch because it's the most common thing that we tend to see. You sit in a slouch position for a long period of time, and you're these pictures. I'm not the most technologically advanced, and so the person who helped me put this presentation put the pictures in. Now that I look back on it, I probably wouldn't do the same thing again. The first thing I see are those red lightning bolts. You should do your best not to scare the patient. So I probably wouldn't use these red lightning bolts again. I want to put that in. I don't have the energy to go back and change these presentations right now. This is mostly for clinicians, and so just know, take the lightning bolts out if you're going to use a picture like that. Anyway, so if you sit in a prolonged positioning, you may create tissues to become ischemic, which is one of the theories behind that pain. You get out of that position, and the pain goes away immediately and doesn't come back. It may simply require postural correction. Postural correction does not always mean taking them into an upright position. It may actually mean letting them slouch a little bit. Centralization, peripheralization. MJ, thanks for putting these pictures in here. These are actually pictures that I keep, because these are, even if it is a frown face and it does show the red line, I want the patient to know that that's not a good thing. And there are some cases where you may have to scare the patient. And this is one of the cases where I will try to, if it works, and the patient's not buying anything else, I'll say, look, when the symptoms are going down your leg, it typically leads to a worse clinical picture. And if we can't centralize the patient's symptoms, or the symptoms remain peripheralized, I'll talk about Lena Skyte's article. I believe it was 2005. Again, I don't have it in front of me, but I believe it's 2005 from SKYTTE. You can look it up. And I'll talk to them, that patients who peripheralize, they're 6 times more likely to require an invasive technique in order to reduce symptoms. And usually that gets the patient's attention. When to say when. Red light. Stop. Okay, everybody knows red light. Baseline pain increases and remains worse. Again, that 20 minutes is typically the cutoff. At baseline, they have no pain, and then you produce pain, and then the pain remains worse. You peripheralize the patient's pain, and then you increase the distal pain, and it remains worse. And that's the red light. This is the introduction to the algorithm. I can remember once I was teaching in one of the old school rooms that had a blackboard still, and the student asked, well, can you run through the algorithm real quick as to like what you would do with each thing? And I said, yeah, sure. Tomorrow we'll cover this. And so I started all the way at the beginning with extension, and you'll see this algorithm kind of play out as it goes through the slides. But I started off with extension, and if extension makes the patient better or centralizes their symptoms or improves their range of motion, that's a green light. If extension peripheralizes their symptoms or makes their patient symptoms increase, if peripheralizes, increased, worse, or changes the range of motion in a negative way, that's a red light. If there's no effect, that's a yellow light. And so for each one of these lights, it takes you off into a different direction. And then the next thing that you do to the patient after it takes you into a different direction introduces a new algorithm. And so I wrote the algorithm all the way across the chalkboard, and I said, that's step 1. Students were like, no. But again, it takes a long time to get there. I didn't realize how long the actual algorithm is, because it's literally those people who are practicing this and doing this for a long period of time. It's in your head. It's just breathing, Yellow light. I'll give you my thoughts on yellow lights. I always try to turn a yellow light red. Some people they hope to turn a yellow light green. I always try to turn a yellow light red. I want to make that yellow light tell me no, tell me to stop, because I don't have a lot of experience with yellow lights turning green. That things that don't have an effect magically make the patient better, but things that don't have an effect, if I do it over the course of time and I do it hard enough, might make them worse, and at least produce symptoms, and then remain worse for a few minutes afterwards. And so I'm looking for something to tell me to stop on day 1 if I can't figure out what's going on. And so yellow light, the one thing that you'll keep seeing is not worse, not better. So doesn't matter what you do, but overall you have no effect on this patient's symptoms. Green light, you centralize, they get stronger, their pain goes away, their movement's better, their range of motion's awesome, their dural tension test changes in a positive fashion. Everything is what happens afterwards. It's better, okay? And doesn't matter which objective measure you're looking at. With that, go. If a patient has a directional preference, and specifically a directional preference towards extension, I tell the patient to, go treat your own back. I don't care if they buy it on Amazon. I'll find it for them on their phone, and then say, I want you to find this book. If you got a library card, go see if you have it at the library. It's not that expensive, But that book is specifically written for extension responders. Extension responders do well with that book. And, you know, if it's a lateral component, maybe not so much because there's a little bit more thinking that goes into it. If it's a flexion responder, maybe not so much. There's a little bit more thinking that goes into it. But for extension responders, I tell them to go buy the book. There is a research article that's out there. Again, I have heavy on research. You know, I've had 10 years to read. There's research out there that discusses, I think it was 16 chiropractic visits versus 1 visit plus treat your own back. And they looked at the effects. When you say it like this, big picture, there was no effect between the 2 patient groups, those that got treat your own back versus those that received 16 visits. And so if that's the end outcome, treat your own back is $7. This is my own personal thing now. Again, this is all me. This is my thoughts. This is how I treat patients. I want a patient for life. I don't want a patient to exhaust their benefits today and then say, you know what, that guy didn't help me. I want a patient for life. So if they have a back pain now, I want them to get better. And if it means that I can give them something that's only going to cost them $7 and they can get better on their own, but when they have, my name's in the book typically. I'll usually write my name in the book and give the patient a way to contact me. Typically phone number, you know, call me if there's any problems. They're not discharged at that point, but, you know, they're discharged enough for them to go home and work on it, and then I follow up with them in a couple of weeks. Or if they're any worse, they come back in. Anyway, but I want that patient to think of me first. And so if their back pain gets better just by treat your own back, and then they have a knee pain, I want them to call me before they call anybody else for their knee pain. Because I was fiscally responsible. And that's gosh, there's so many tangents. If you take students and you look at that financially responsible or fiscal responsibility portion of the CPI, this falls into that. Is the student doing their best to make sure that they're giving the patient value? And sometimes it's more valuable for us to send that patient home to work on exercises than it is for them to keep coming into therapy 3 times a week. Fiscal responsibility goes well beyond just charging the patient for the time that they're in the clinic. You have to look at the way that you can increase the value of your service for the patient. Anyway, soapbox done. Repeated movements with derangements. You go in the wrong direction or the wrong force and you're going to make them worse. You're either going to worsen their dural sign, you're going to worsen their strength, you're going to the strength stuff that you worsen and improve, man, that is amazing to see. Like, when I have a student and the patient goes from being strong to being weak, it just blows their mind. Or they go from a straight leg raise of 30 to a straight leg raise of 70, blows their mind. I absolutely love doing stuff like that. And so a lot of the times if the patient reports that they're centralizing and they're improving, I don't tend to go back and do all the mechanical testing again, because centralization is, there's a research article that, a written article that came out of the McKenzie Institute International, I think, that said, is centralization a trump card? This was probably 2009, 2008. Anyway, and so if you see centralization, you know you're dealing with something really good. You don't necessarily have to go back and retest everything. But if you're not getting that subjective improvement, you go back. You do have to go back and test your mechanicals to see if they're changing. So yeah, wrong direction, wrong force, wrong response. Right direction, right force, right response. If no change, force progress to find the red light. I try to force progress to find the red light. Red light, I make something tell me stop. Repeated movements in the dysfunction syndrome. End range pain on every occasion performed, but no worse overall. Hurt does not equal harm. Again, this is where we start explaining pain. That not all pain means that there's some damage. You won't see a rapid change in mechanics. You're really looking at that creep hysteresis set. If you're in PT, those 3 words you should know. If you're a student that's going to come into one of my clinicals, know those words. Move towards the direction of pain to remodel the adaptively shortened tissue. Repeated movements in the postural syndrome. Remember, postural syndrome, when you change position, your symptoms go away. You're overall fine. And so repeated movements doesn't give you anything. Selecting repeated movements in MDT, sagittal planes are always explored first, unless you have an obvious lateral shift. And even with an obvious lateral shift, doesn't mean it's relevant. My example before should have shown that. And then frontal planes are introduced if sagittal planes worsen or peripheralize. I've changed a little bit, and I'll be honest with you. I don't necessarily always exhaust extension first, but I always follow my variables. And so this is one of those things where I had a conversation with Mackenzie Diplomat, one of the professors of the system, and he said that he doesn't necessarily follow one direction fully first, because sometimes it's just more convenient to try something different, try a different direction, or I'll just give you the example, right? So let's say that I have a patient already on their belly, and I'm already looking at extension, and I've exhausted extension. I may look at hips off-centered prior to going to flexion, or I may go to flexion rotation prior to going to flexion, and that's purely just based off of the stuff that I'm seeing in the clinic or what I hear from that patient's history. But I'll always come back to it if it's not responding in a good, better fashion. You know, if the patient's not improving over the course of time, then you go back to follow your variables. And so you're essentially just rolling things out as you're moving through your evaluation. Sorry. Flexion and lying versus flexion and standing. Gravity, bottom up versus top down. So when you stand up and flex, you get the bottom top down mechanics, meaning that you get the superior vertebrae anterior translating over the inferior vertebrae. If you do bottom up, you get the inferior vertebrae anterior translating over the superior vertebrae, if that made sense. And then you also have to know that there's a difference in the dural tension. Flexion and lying is typically done with knees bent. Flexion and standing is done with knees straight. So it changes the dural tension. Repeated movement exam. Flexion and standing. Sorry, I'm trying to check to see how long I've been going at this. May take a break here soon. Flexion and standing. You're looking at the symptomatic response prior, before, and after. Extension and standing, same thing. That's a back bend. Hands on the small of the back for a fulcrum effect. Flexion and lying is double knees to chest. Extension and lying is the press up. A lot of people don't know how to do a press up. And it shocks me. Like, a lot of therapists don't know how to do a press up. I had one therapist show me a press up, and it was literally prone on elbows with like scapular, they just did that push-up plus position, and I was shocked that they didn't know what a press-up was. I asked them to show me a cobra, and man, they jumped right into what looked like the perfect press-up. Maybe a person who was doing a lot of yoga. Anyway, and so you're always trying to assess end range response. And with extension and lying, ideally you would have the hands underneath the shoulders, and you go to end range. If they can't get there, if their pelvis is rolling off the table, assuming that they've kept their heels apart, they're nice and relaxed, and they just lack that motion, you may have them move their hands forward some to reduce the lever arm or the length of the lever so they don't go up as high. But you're always trying to get that patient to that patient's end range. Side gliding and standing. Don't do a side bend. Like I said before, 95% of the issues with the lumbar spine are 405, L5S1. So yeah, side bending may not give you any information. You call it in the direction that the shoulders move. So again, when you're looking at the lumbar spine, if you go into flexion, because the superior segment glides anterior over the inferior segment. Extension is because it glides posterior. If it glides to the right, that is a right side glide. Glides to the left, it's the left side glide. And so you can call it in the direction that the shoulders move. The trunk remains neutral, and the shoulders should be parallel to the ground. You're shifting the pelvis away. Sustained postures give you more force than repeated movements. Again, look at pre-hysteresis set. And then overpressure if needed to expose an inconclusive exam. Manual therapy. Some people say that MDT is a hands-off method. I disagree. It's a hands-on when needed. It's just manual is not the first technique used, and I honestly I don't believe it should be the first technique used, whether it's soft tissue or what have you. That's just me personally, because you have to fully understand the patient's symptoms before you can start treating. And so if you're using manual therapy as a treatment approach, but yet you don't fully understand the patient's symptoms, it may not be the most appropriate intervention. So initially, manual therapy may be used just to help you understand the patient's symptoms. The presence of mechanical syndrome should be determined within 5 treatment sessions. I think Wernicke takes it up to 7 treatment sessions to find centralization. Early forces are patient-generated, which means that we stay hands-off if the patient is improving and then progress towards PT-generated if needed. Not hands-on, if needed. Symptomatic presentation, monitor the progress, monitor their site of pain. Are they peripheralizing or centralizing? Has their pain changed from intermittent to constant or constant to intermittent? Has the severity changed? Are their numbness and tingling changing? Or tightness, is that changing? Is the number of pain meds needed throughout the day changing? Is their pain on movement changing? You're always looking at how your interventions are changing the patient's symptoms. And this is another reason why you try your best not to give the patient too many interventions. Because if you give the patient, and I see it frequently, and I'm sure if you're a therapist, you may do it. If you give the patient extension of lying and flexion of lying, and the patient comes back in and says, I'm worse, what did it? Was it flexion or extension? And so you want to try to remove as many variables as possible when you're trying to assess patient response. Peripheralization and non-centralization is associated with a poor prognosis. Mark Wernicke is one of the quick story on Wernicke. It must have been Baltimore, Baltimore 2010. You know, I was a dork. I'm still a dork, obviously. I'm sitting here doing Facebook Live presentations. And you don't get to see my face at all. So anyway, but I was a major dork, and so for me, you know, I rarely ever got starstruck. You know, I had plenty of opportunities to meet celebrities. You know, I mean, I remember as a child, you know, with some of my friends meeting Michael Jordan. Not starstruck. Following Michael Jordan, I'll say it that way. Not starstruck. Anyway. But Mark Wernicke, man, I brought the journal article with me. I asked him for his autograph. I mean, guy, he starstruck. Anyway, so paresthesias, criteria for improvement. Numbness becomes tingling. Severity of numbness lessens. Constantly becomes intermittent. Area of paresthesias may lessen. You're always assessing the symptomatic response. You know, it is vital we know their previous status prior to testing, and then we know what's happening before, during, and after. I'm going to stop there because this starts up the objective evaluation, it looks like. So if you have any questions, feel free to ask. You can find me on Facebook. You can PM me. But so far, I think we're about halfway through this presentation.